It's my pleasure to introduce Dr. Leah Rickler, who's an assistant professor of psychiatry and oversees the resident geriatric psychiatry clinic, who will introduce today's speaker.
Yikes. Hi, everybody. It is an absolute pleasure and honor to introduce Dr. Howard Nguyen. He is one of our delightful residents. He's kicking off the resident grand rounds that are coming up. And Howard comes to us from sunny SoCal, where he was born and raised. He received his bachelor's degree in human biology from UCSD in 2012, and then a master's in biology in 2013. He then went off and did some research in the hippocampal neurogenesis of non-human primates, and then realized that he wanted to be a physician and received his DO from Western University College of Osteopathic Medicine of the Pacific in 2019. And then he wonderfully came and joined us here at UMass. He discovered early on his passion for geriatric psychiatry and actually received the American Association of Geriatric Psychiatry Honor Scholar Award in 2020. He has spent the last year as the chief of our program and also the chief of geriatric psychiatry, which has meant that he has spent time with me in the Geri Psych clinic, where patients and colleagues alike just comment constantly on how wonderful he is and what a fantastic provider he is. He's going to be telling us today about managing and caring for older adults. And then next year, he's going off to complete fellowship in geriatric psychiatry at UCSD. So let's all welcome him. He's going to tell us how to age well with healthy aging and resilience, revisiting an age-old discussion. Thanks, Dr. Nguyen.
Thank you, Dr. Richler, for such a kind introduction. So today's topic is, like she said, going to be on healthy aging and resilience. I have no conflicts of interest to disclose. So the inspiration for today's talk comes from my own personal experiences, the past few years in residency training, and lengthy discussions with my mentors and colleagues. In working with Dr. Richler this past year in our Geri Psych clinic, we were seeing so many depressed people, all with very complex psychosocial situations that were complicated by neuropsychiatric illness. And I just so happened to be reading Man's Search for Meaning at the time, recommended to me by my colleague. And it had me thinking about this concept of resilience and the factors that help us overcome adversity. Our patients come to see us when they are sick, and we partner with them on a journey in search of health. In today's talk, I want to inspire us to be a little more strength-based when evaluating and treating our patients. And finally, Elderhood by Louise Aronson, a geriatrician based out of San Francisco, recommended to me by Dr. Richler, has been a highly influential book in changing how I view older adults. About 50 million American adults are over the age of 65. And by 2060, this number is expected to double. So the silver tsunami is very real. It's imperative that we start understanding the unique struggles of this population so that we can better treat them. I hope that by the end of this talk, we have a little more understanding and appreciation for our older adults. So the objectives for today's talk include deconstructing stigma around aging. So for much of history and even in today's society, we value the health and lives of our young folks. This inherent bias is rooted in negative stigma that still surrounds the concept of aging. Next, redefining the meaning of old. Increased lifespans and improved functioning in later years demand that we reevaluate our conceptualization of older people. Next, address the unique challenges with aging. Though lifespans are getting longer and people are remaining independent and functional for longer, the aging population have their own strengths, weaknesses, accomplishments, and shortcomings. Next, identify factors associated with resilience so we can hone in and cultivate qualities that help our patients transition through the years. And finally, understand how to promote a healthy population and encourage a thriving population. I wanted to start off the talk with a quote. Thus, suffering completely fills the human soul and conscious mind, no matter whether the suffering is great or little. Therefore, the size of human suffering is absolutely relative. So first, a little history lesson. For millennia, we have obsessed over the process of aging, often symbolized by the pursuit of immortality or eternal youth. This phenomenon has been observed across multiple civilizations, including ancient Greece, Arabia, Persia, Europe, and Egypt. It spanned across religions, including Norse, Hinduism, and Abrahamic religions. Age was an illness, something to be cured, as it was an indicator of a failing body. And I think this quote by Cicero sums it up quite well. As I give thought to the matter, I find 4 causes for the apparent misery of old age. First, it withdraws us from active accomplishments. Second, it renders the body less powerful. Third, it deprives us of almost all forms of enjoyment. Fourth, it stands not far from death. Even in modern history, we continue to be obsessed with youth. Galen, a physician in the 2nd century AD, was one of the first to postulate that age is, in fact, not an illness. It is an unavoidable part of life. And yet, the prevailing sentiment for centuries after and well into the 18th century remained that aging is an illness and something to be fixed. The Fountain of Youth, a mythical pursuit stemming back to the 5th century BC, was an ongoing pursuit into the 1600s. One work from Jakob Hutter in 1732, titled "That Senescence Itself is an Illness," quotes that aging is a progressive hardening of all fibers of the body, leading to weakened blood flow, and this stagnation led to fatal putrefaction. Basically, that aging is a direct cause of death. In today's era, the anti-aging market size is approximated to be $60 billion, with an increase to $120 billion by 2030. Botox, fillers, creams, surgeries, all to appear younger. And what does this say about how we view the process of aging? That it's something inherently shameful, a sign of weakness and of a failing body. And through these millennia, our perspective on being old has been deeply woven into the fabric of our society. I want us to play a game. When I say the word old, I want people to think to themselves, what comes to mind? What other words do you associate with being old? And what does it connote? The word old is often associated with deterioration, obsolescence, antiquation, decrepitness. When calling someone old, there's usually a pejorative context to it. What if I had you do the same exercise with the word elderly? Here, you might notice slightly different words coming to mind. Some of you probably even thought of the words wise or sage. However, many people still find it to connote frailty, feebleness, dependence, and limitations. And if you look through any of the literature in recent years, you'll find that the term older adult is commonly used. In fact, there's been a shift in attitudes to utilize this term, even in the general population. A poll of 2,700 people by NPR about 1 decade ago revealed that 43% of these people preferred the term older adult. 1/3 preferred the word elder, but people don't readily identify with this category. Everything else like old, senior citizen, even geriatric were frowned upon. In some surveys in the UK, the term older adult was favored by over 80% of people polled. The term older adult continues to grow in popularity because it denotes a transition in one's life, as opposed to a distinct category of human. But that then leads to the question, when does someone classify as older? Age is not adequate as a sole cutoff. After all, these days, at 65, one person might already be dementing, while another might still be working full-time in a high-powered academic position. Dwight Schrute from The Office said it best, age is just a number, false, age is just a word. So how do we define an older adult? A Marist poll in 2016 showed that 2/3 of people don't even consider age 65 to be old anymore. In fact, people are now considering it middle age. Age is part of the equation, but we have to take into consideration the whole person. Similarly, we don't really define people as old just by their cognitive abilities, their disabilities, or their medical conditions. The 5M model is one that was created by the American Geriatric Society, and is used widely in the field to help us conceptualize our patients and their frailty. The overarching M stands for multi-complexity, which describes the whole person, an older adult who's living with multiple illnesses and has advanced or complicated biopsychosocial needs. The 4 remaining M's refer to domains of consideration. So we need to consider their mind, which includes things like mentation, cognitive ability, delirium, and psychiatric illness. Mobility, which includes their level of functioning, gait, balance, driving, risk of falls. Medications, which involves polypharmacy, deprescribing, optimal prescribing, minimizing adverse medication effects and medication burden. And finally, what matters most, the acknowledgement that each individual has their own meaningful health goals and care preferences. And it's by this model that we can understand why many 65-year-olds consider themselves midlife, because they're still cognitively intact, still functioning independently, and on relatively few medications. Only about 1 in 4 of all older adults have a disability, whether it's cognitive, sensory, or mobility. And most of this is in people over 85. In the realm of psychiatry specifically, older adults unsurprisingly struggle with their own problems that profoundly affect their quality of life and ability to age healthily. The World Health Organization approximates that about 15% of people over 60 struggle with some form of mental illness, and that 6.6% of disabilities in this population are due to mental illness. And about 7% of older adults struggle with depression compared to about 5% in the general adult population. Shockingly, about 25% of deaths by suicide are in people over 60 when they account for only 15% of the population. And as we all know, mental illness often comes in multitudes. So where there is depression, there's also anxiety, insomnia, and substance use. And I bring these statistics to hopefully drive home the point that successful aging is the goal, but unfortunately is not the reality for so many of our patients. Older adults with mental illness also have higher rates of chronic illnesses, including diabetes, cardiovascular disease, and lung disease, higher rates of early disability, mortality, poorer physical functioning, and finally, higher rates of poor psychosocial functioning. Even the presence of mental illness increases the perception of poor health in our patients. And you can imagine how this creates a vicious cycle in how one might deal and view their own mortality. For the past 2 years, I've given talks on geriatric depression to my co-residents. And one of the points I really emphasize is that older adults experience depression very differently compared to their general adult cohort. Our ability to accurately identify and diagnose mental illness is far from perfect. And too often, our patients are reduced to symptom checklists. And needless to say, we should be looking beyond just a list of symptoms and asking ourselves about the factors driving their sadness, grief, depression, anxiety, inability to cope, the factors that bring them to our offices. And of course, it goes without saying that treatment has to be tailored to this population because medications just kind of suck. Medications work and they can be so helpful, but we need to know what we're treating. We know that psychotropic medications affect older adults differently. The risk of tardive dyskinesia goes way, way up. Antipsychotic use in patients with dementia come with a black box warning of increased all-cause mortality. SSRIs may result in higher incidences of hyponatremia, and not to mention the multitudes of other adverse effects on cognition, delirium, oversedation, and their interaction with a number of other medications they might be on. Aging as a process is the convergence of medical, psychiatric, and socioeconomic factors. Our approach to treating older adults should incorporate the holistic picture and understanding them beyond a cluster of symptoms. So when a depressed or anxious person comes into our offices, the interview process should be more inclusive than just which medication to pick. As we'll discuss later, there are factors associated with happy, thriving older adults that are often not capitalized. And before we move into the next portion of the talk, I wanted to share this quote with you. At present, we count only a small fraction of medicine's harms, and counting almost exclusively the harms that visibly affect the body or its function while ignoring the scars of violent words, actions, and policies on psyche and relationships. And as we jump into the topic of healthy aging, I wanted to share one of my favorite clips with you all.
This is weird. Hello. Welcome.
Thank you.
Actually reminds me of a Little Britain sketch that I please, could I have your names?
I'm Paddy.
I'm Nico.
And what is the nature of your relationship?
It's a professional one.
And might we ask you your age?
I will be 80 this July.
Do you think you can win the show?
Oh, it would be very nice, but just as long as people enjoy what we're doing and we give people pleasure, that's the main thing.
Okay, well, best of luck.
Fastest routine I've ever seen.
So what did people notice about this video? There's comments of, oh, this is weird. Do you think you can win this show? And even as she performed, a lot of facial expressions of disbelief. And admittedly, when I first saw the clip, my reaction was similar. I didn't even think of the judges or audience's reactions as offensive. But as I thought more about this, I wondered, why are we surprised? In an age where medicine is so advanced, should we have this persistent perception of weakness and frailty associated with older people? Some statistics suggest that between the ages of 75 and 84, 70% of people report no disability. And even after the age of 85, over 40% remain fully functional. Advances in medicine and changes in our lifestyle have transformed our society. This is my grandfather. He just turned 100 this past year. He grew up in rural Vietnam as one of 5 siblings. He moved to the United States in 1982 at the ripe age of 60 with my grandmother and their 8 children. But his life in Vietnam was not easy, especially in the midst of the Vietnam War. He toiled and toiled through hardship, made it to the US, and is now living his best life in sunny California. He contracted COVID last year and required upwards of 6 liters of oxygen, and we all feared for the worst, but he survived. He bounced back and is now off oxygen completely. He's never been happier and is going about his day like COVID never happened. And many of us know someone like this, and I'm sure the question has crossed our minds. How do we live such a fruitful and fulfilling life? Turns out growing old is a fairly complicated process. Most of us start out in a phase of independence in our 60s where we are high functioning with minimal limitations. Living at home and performing our ADLs is no issue. Over time, with accumulated illness, we become interdependent with some minimal reliance on others, typically a significant other. So we might need some help with ADLs or occasional check-ins. Later, this interdependence turns into dependency, where there may be significant difficulty with ADLs. loss of independence accumulates and the person needs consistent monitoring. At this stage, the patient might still be living at home until crisis management, where physical and cognitive limitations become really severe. Patients in crisis management can no longer live at home due to ongoing need for immediate medical attention, and so they often reside in residential care facilities. And finally, the last stage of life is end of life, where focus is placed on having a good death. As you can imagine then, there are so many struggles that accompany the process of aging. There's a sense of purposelessness as older adults face a lot of ageist prejudice. There are many outdated stereotypes about older adults, which can lead to isolation and marginalization in this community. And while we are living longer, financial insecurities exist for many people. Many older adults are still able-bodied, but are unable to find work. And of course, with aging, physical and cognitive decline leading to loss of independence, poor mobility, and inability to be social or engaged in their interests or hobbies. Healthcare can also be very fragmented and complicated for older adults, and coordination of care can be quite complex. And all of this presents as issues in access to care. One of the most stressful parts of aging is alternative placements outside of the home. Finding the right care provision. Some people grow into complete dependence, and caregivers need to be trained to provide adequate support, both physically and emotionally. And finally, facing their own mortality and making end-of-life preparations, which has a lot of financial implications, but also requires lots of planning and thoughtfulness so that the individual's wishes are respected. So at this point, you might be wondering, what does it mean to age successfully? Is it successful cognitive and emotional age? Freedom from disease and disability? Mitigating deterioration? There are so many domains to consider, and yet the concept of successful or healthy aging is a relatively new one. In fact, this concept first showed up in the literature in the 1960s, and at that time, the emphasis was on longevity. The first models of successful aging came about in the 1970s and 1980s, and the emphasis still was on separating pathologic aging from normal aging. There was no discussion of successful aging, which is the upper end of the spectrum. And if we review the literature from the past few decades, it becomes apparent that healthy or successful aging involves good physical functioning. But beyond that, there seemed to be no consensus on what it actually meant. Quantitative studies often measured physical functioning, but qualitative studies focused more on adaptation to illness, psychological traits, and engagement. Now, meta-analyses and more recent studies show that healthy aging is complex and encompasses all of these things. The World Health Organization in 2002 put forth a framework for active aging, where the focus was to extend healthy life expectancy and quality of life. Over the following decade, the organization changed their stance on how aging should be approached, not just active, but healthy. They defined healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. Functional ability emphasizes having the capability to be and to do what they value. This includes ability for meeting basic needs, making decisions, mobility, building and maintaining relationships, and contributing to society. Functional ability falls into two domains: environmental factors and intrinsic capacity of the individual or personal factors. Environmental factors include things like the home, the community, broader society, attitudes, values, policies, systems in place. Whereas personal factors include both mental and physical capacities, things like the ability to walk, think, hear, see. It also includes psychological traits like optimism, personality structures, cognitive flexibility, adaptability. And these principles were informed by many well-designed studies over the years, and I want to discuss with you two of them today. The first is the Berlin Aging Study, which was done in the early 1990s, and it was a multidisciplinary investigation that involved psychiatry, psychology, geriatric medicine, sociology, and it surveyed over 500 people between the ages of 70 and 100. The participants were examined over a series of 14 sessions that involved extensive interviews and evaluations from these various disciplines. The big takeaway was that with age, people developed more spirituality and serenity. Serenity was defined as increased faith or acceptance that a greater power was going to take over. And though some of the participants were on multiple medications and were chronically ill in the eyes of their physicians and others in society, they do not regard themselves as being sick. The researchers found that this pattern is rooted in and is reflective of the coping skills found in older adults: humor and the ability to compare themselves to those who were worse off. Furthermore, two of the most important psychosocial predictors of successful aging were education and presence of an extended family network. The educational status reflected a person's planfulness, or how carefully they thought about their future and goals and their likelihood of executing that successfully. Poor aging, on the other hand, correlated with dependence, dissatisfaction with life, being disabled or bedridden, mobility issues, sensory issues, depression, and dementia. There's now an ongoing Berlin Aging Study 2, which is comparing two groups, the first consisting of 1,600 people between the ages of 60 and 80, and the second of 600 people between the ages of 20 and 35. The second study I wanted to bring up today is the study of adult development at Harvard. This is one of the most influential studies about aging to have ever come out, and the data from the study continues to be published today, some of which we're going to discuss later. The study was funded by two grants, one for 268 men who graduated from Harvard in the early 1940s, and the other for 456 men from the inner city of Boston. The truly spectacular thing about the study is that it's longitudinal. The researchers were following people as they aged with biannual check-ins. And with these check-ins, the researchers were able to gather information about developments in mental and physical health, career enjoyment, retirement experiences, even marital quality. The initial results were pretty clear, and some of them include alcoholism is bad, as it led to divorce and correlated with depression and early morbidity and mortality. Political leaning correlated with intimacy, with more liberal-minded men having active sex lives into their 80s, and conservative men ceasing to have sexual relations at an average age of 68. Warmth of childhood relationship with mothers predicted financial success and was correlated with reduced rates of dementia. On the other hand, warmth of childhood relationship with fathers corresponded with lower rates of anxiety, greater enjoyment of vacations, and increased life satisfaction after age 75. So at this point, we know what it looks like to age healthily, someone who is mobile, involved socially, in good mental, emotional, and physical health. Why then do some people age more healthily than others? What is the secret? Well, it's no secret that aging can be a difficult process. The World Health Organization splits the process of aging into three phases. The first phase captures high level of functional ability coupled with high intrinsic capacity. This is when a person is otherwise healthy and can be fully engaged in relationships, society, and the things that matter to them. We prolong this phase by preventing and mitigating chronic illness. And we also promote capacity-enhancing behaviors. For example, promotion of socialization will deepen one's sense of purpose and quality of relationships. In the second phase, there's a decline in intrinsic capacity due to progressive medical conditions. The goal here is to slow the decline if possible. At this point, we start looking for ways to compensate for loss of capacity. In the third phase, there is a substantial loss of intrinsic capacity, and we now have to manage advanced chronic conditions. The observed decline is complicated by multimorbidity, essentially where multiple illnesses lead to interactions between different disorders, between one disorder and treatment recommendations for another, and different drugs prescribed for different disorders. So we need to start ensuring a dignified late life, and efforts shift from promoting behaviors to heavy compensation for the loss of capacity. Homeostenosis is a concept that was developed in the 1940s to describe the decreased potential of a cell, tissue, or organ system to function beyond its basal level in response to changes in physiologic demands. Essentially, our physiologic reserves diminish as we age. The endpoint of homeostasis is frailty, where essentially anything can overwhelm the available reserves, and this results in catastrophe, including death. This loss of physiologic reserve helps to explain why some older adults compared to younger adults have a more difficult time in bouncing back after an admission or a bout of medical illness. But it doesn't really adequately explain why some older adults might bounce back better than someone else in their peer group. And this is where the concept of resilience comes in. Resilience has been defined by several different organizations and settings to be the ability to bounce back following a stressful or adverse event in life. And this applies to both mental and physical health. Resilience in older adults is associated with many benefits. Studies repeatedly show that resilient adults have increased positive emotions, optimism, better coping styles, and overall happiness. Highly resilient individuals are also observed to have longer lifespans, increased length of independence, and overall lower burden of chronic illness. There's also some evidence that resilience leads to improved cognitive functioning as we age and a decreased risk of Alzheimer's disease. And finally, resilient individuals find themselves more involved with their communities, have more contact with their loved ones, and have an increased sense of purpose in retirement. And when we look at highly resilient individuals, we find that there are several other factors that are correlated with this attribute. Studies have looked at both personal and community factors that are associated with resilient people. There's a strong correlation between resilience and healthier lifestyles, optimism, sense of purpose, and self-efficacy. There's low to moderate correlation with overall life satisfaction, morale, positive emotions, spirituality, and physical functioning. And when we look at community factors, there are no strongly correlated factors, but we do find that resilient individuals tend to be higher educated, have overall higher income, have bigger social networks, and more identified social support. So this seems to suggest that resiliency and all of these other really wonderful things function bidirectionally. The factors that predict resiliency are similar to the results of being resilient. People who are resilient have all these other benefits, but it is likely that having these personal and environmental factors can help a person become more resilient as well. Another quote break. This one is from Atul Gawande. You may not control life circumstances, but getting to be the author of your life means getting to control what you do with them. I thought this quote was really apt as we move into the next portion of today's talk. How do we cultivate resilience and reap all of these really wonderful benefits? Are some people just doomed with poor resilience? The answer is no. The American Psychological Association defines resilience as being a process and not a personality trait. So people have the capacity to build resilience over time. So what are some ways in which we can become more resilient ourselves and also help our patients become more resilient? It turns out that Erickson was onto something when he described his stages of growth. Research now is showing that what we do in our adulthood, or stage 7 on this diagram, can help build resilience. Generativity is a period in our lives where we develop a focused interest in establishing and guiding the next generation. There's a fundamental shift in focus on ourselves to focus on ensuring the well-being of future generations and society as a whole. A longitudinal qualitative study of people on the island of Kauai between 1950s and 1980s demonstrated that people who display resilience, even in the face of childhood and early adult adversity, were the same ones who demonstrated personal and generative growth. That is, these individuals sought out both continued self-development and opportunities to help others. And from the study of adult development we discussed earlier, the researchers in the 1980s found retrospective data that achievement of midlife generativity produced a resilient effect in men who experienced heavy combat during World War II, which then is positively associated with later life physical and psychosocial health. In 2014, from the same group at MGH, the study of adult development published another study to build upon that data. In this study, they used 2 measures of adverse childhood experiences: lower social childhood class and harsh parenting. They found that, yes, presence of ACEs led to poorer later life health, as well as lower chances of achieving generativity in midlife. But we know from previous studies that resilient individuals will continue to engage in positive psychosocial growth and development despite exposure to ACEs. This study again confirmed that resilience helped mitigate the effects of ACEs in both the Harvard sample and the inner city cohort. Furthermore, it was the achievement of midlife generativity that mediated the effects of these two ACEs and helped people adjust to aging later in life. Adjustment to aging was gauged by a questionnaire spanning multiple areas, including meaning and satisfaction found in career, marriage, leisure, retirement, and psychological well-being. Men who grew up in a lower socioeconomic class and did not achieve midlife generativity overall fared worse when it came to later life adjustment. Those who did achieve midlife generativity were better adjusted in late life. So it's believed that the achievement of generativity increases one's capacity to successfully cope with stressors by changing the focus from one's own life to a focus on their loved ones and their community at large. And also from the study of adult development, researchers found that maturity of defense mechanisms play a crucial role in building relationships, which we know contributes to better late life physical and emotional health. Mature defenses were defined as suppression, humor, altruism, sublimation, and anticipation. Immature defenses were defined as projection, passive aggression, acting out, and denial. There was also an intermediate category for repression, displacement, and reaction formation. An individual's defense maturity was determined by both questionnaire as well as extensive interview. This study found that men with immature defenses as young adults struggled with higher rates of chronic health problems between the ages of 30 and 60. And this was reassessed every 5 years. People who had more adaptive defenses earlier in life had more optimism and better subjective physical functioning later in life. Essentially, people with mature defenses felt that they could do more if given the same circumstances as those with immature or primitive defenses. And importantly, this study found that mature defenses leads to more robust social involvement, which then leads to improved physical and emotional health. The strength of our relationships is repeatedly demonstrated to be really, really important. Warmth in our relationships is associated with lower rates of mortality from cardiovascular disease, cancer, and infectious disease. Even perceived social support is associated with lower mortality rate. And specifically in people over 65, strong social involvement is associated with lower levels of mental illness, cognitive impairment, and physical ability or disability. We now know that warm childhood relationships often grow into warmer and more secure relationships in adulthood, and this allows for people to overcome challenging and adverse events. Learning how to cope with stress in a healthy manner is crucial because it makes it easier for other people to be with and around you. So this leads to increased social support and ultimately healthier aging. So it's not only the amount of social supports that we have, but the quality of our relationships. And it's important to promote qualities like generativity and adaptive defense mechanisms in our patients. And to do so, it takes continual improvements in how we approach patient care. The 4P model of medicine can help guide this. So the prediction is pretty clear. There's going to be a silver tsunami with a massive increase in older adults in coming years. And during this talk, I hope I impressed upon you the important relationship between chronic medical illnesses and emotional well-being. We now know that this is a two-way street, and we should be intervening when we can to reduce burden of illness earlier in life. And as mental health providers, we're already very familiar with individualized treatment because of our biopsychosocial formulations. There's no typical older person. Some 80-year-olds have the physical and mental capacities of a 30-year-old, while others of the same age might be struggling with basic ADLs. I think especially in psychiatry, we can do more to expand on this in our encounters because our medication visits may be infrequent and time limited. But if there's one thing that I've learned this past year in Geriatric clinic is that sometimes opening a conversation about someone's hopes, dreams, failures, and struggles can be so much more meaningful and impactful than a quick dose adjustment. And finally, care is becoming more and more participatory. Patients are engaged in their own well-being. And this is something not only to be embraced, but encouraged. This is where patients fill us in on their care preferences, what is truly important to them as they age, and how they want to deal with hurdles that arise. And again, the World Health Organization actually has their own initiative to promote a healthier aging population. They propose a three-pronged approach. The first being more funding for specialized training. This includes everything from preventing and managing age-related chronic illnesses, mental illnesses, substance use, neurodegenerative disease. And this also includes more sustainable policies on long-term and palliative care and development of age-friendly services, basically making access to care easier for older adults. The second prong is health promotion, providing security and freedom as people age, which involves adequate housing through more supportive policies, social support for older people and their caregivers, health and social programs targeted at vulnerable groups, such as those who live alone or in rural areas. We could also benefit from more awareness of elder abuse and community development for more social engagement. And finally, the third prong would be an emphasis on early diagnosis of issues that come up, whether physical or emotional. This allows us to optimize physical and mental health to ensure well-being into later life. The research I presented today was conducted primarily in a Caucasian population, mostly men. Obviously, we treat more than just older white men. The relationships we have with our environments are shaped by many factors, including family of origin, ethnicity, level of education, financial resources. Unfortunately, the data is pretty scarce when looking at resilience in older adults across different ethnic backgrounds. However, there's data that looks at cultural attitudes toward each aging population. One meta-analysis found that societies with a larger aging population tended to have youth with more negative perspectives of older adults. Furthermore, societies with an emphasis on collectivism as opposed to individualism tended to have more negative perspectives toward older adults as well. And when examining Asian societies in particular, though they might associate older adults with more wisdom and respect, there still persists an attitude that older adults are less attractive, less capable, and unable to learn new skills. Despite this, we find that societies that emphasize concepts like collectivism and filial piety have some of the most successful agers, which makes sense based on what we just discussed. But currently, there's a huge gap in knowledge in understanding the effects of race and culture on aging, on healthy aging. And we can look at some of the models that currently exist in the US and abroad to see what efforts are being made to ensure a thriving population. The PACE program is a really awesome resource for older adults. It stands for Program of All-Inclusive Care for the Elderly, and the goal is to help them age at home. It is funded by both Medicare and Medicaid, and so it's available across different states. PACE helps provide comprehensive medical and social services in the community. Essentially, the individual would be receiving care from a large team of professionals, and this would include primary care, medical subspecialties, psychology, psychiatry, occupational and physical therapy, social work, visiting nurses, transportation. And this all happens under one roof. And this allows people to live in the community instead of receiving care in a nursing home. At present, it's estimated that about 5% of older adults live in a nursing home at any given time. If we break this down further, 1.1% of people between 65 and 74, 3.5% of people between 75 and 84, and 13.2% of people over 85. But due to the financing, PACE allows providers to deliver any and all services that are needed by the patient. So this is really, really huge because people want to live at home. There's a sense of individuality, independence, and well-being that are all crucial to healthy aging. Unnecessary use of the hospital or nursing home is something we all want to avoid. So PACE is a wonderful resource, but it isn't perfect. Not every state has a PACE program. And even in the states that do have a PACE program, it can be quite limited geographically. An application into the program can be a very lengthy process. So not a perfect program, but definitely a good place to start. And throughout my talk so far, I haven't really mentioned much about dementia. needless to say, demented people also struggle with aging. Our current healthcare system does a pretty horrendous job when it comes to these patients. Over the past few years, there's been multiple articles in the media about the maltreatment and over-medication of demented patients. I think we can all agree that this would be the definition of poor aging, not to mention the iatrogenic harm for patients. Village Landais is an example from France that shows us how care for older adults has a lot of room to improve or change. So it's a movement to make memory care units less like a cold, sterile hospital or a skilled nursing facility and more like a lived-in neighborhood. The goal is to help patients feel like they can still engage in activities and have some sense of independence. Our current model of care has an emphasis on keeping residents safe and healthy, which is all very reasonable. But what does it mean to have a good life with Alzheimer's disease or any other neurodegenerative disorder? So there's something inherently dehumanizing about the way we currently treat our demented patients. And while the concept of a dementia village may come with its risks like falls and accidental injuries, it's also associated with a lot of benefits. Actually at the Village Landais, there's over 100 people who live full-time on 17 acres that are divided into small clusters of neighborhoods. And each house has 2 staff members who are trained and specialize in home care and occupational therapy. And there are various facilities across the campgrounds like restaurants, salons, grocery stores, hobbies, and much more, where residents are encouraged to be more socially engaged. And the emphasis is placed on having positive experiences. As long as people are able to perform tasks, they are allowed to do them. And in France, this is being paid primarily by the government, though families still pay a small fee to help with the cost of running such a large-scale operation. And right now, there's no official data from this model, but the hope is that compared to traditional SNFs and memory units, this type of setting can help slow the progression of dementing illness, lead to less behavioral dysregulation and fewer hospitalizations. And even if this model doesn't work out, I think it's evidence that, maybe our approach and our care of our older adults can be transformed. So I actually included a video on dementia villages, but for the sake of time, we'll skip it. But I really do encourage anybody who's interested in this topic to check out this video. It interviews one of the founders of the original dementia village over in Denmark. And it's really, really cool. No bias. So in conclusion, we learned today that aging is a complex multifactorial process. Resilience can help mitigate the effects of aging when it comes to both physical and mental illness. One of the most important things we can do to build this resilience is expand our social network, invest in our relationships, find purpose in our lives. And yes, this was an hour-long presentation to drive home the point that we can all benefit from warm relationships. So I encourage you all to reach out to a loved one today. And finally, there's so much room for improvement, both in our individual approach, but also on a systems level. And I wanted to end the talk with one final quote. One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. And I have a quick comic, it's 30 seconds.
Doctor, I've been having trouble lately with minor injuries, such as I'll jam my finger trying to get something out of a drawer, and now it's like my finger just hurts for the rest of my life. Yes, that sounds right. What do you mean? You're getting older. This is just what happens. But I'm only 35. How are there people in their 70s? Now you understand why they are so grumpy. But I'm already the grumpiest person I know. Don't worry, you'll unlock a new level of grumpiness after we get these test results.
Yeah, and of course, thank you to everybody who's helped me in this long journey that we call medical training. My family, co-residents, all my attendings and supervisors, all the program coordinators, and notable thanks to these 3 lovely mentors you see up here. Dr. Padilla for always listening with such compassion, encouraging me to tap into my strengths. Dr. Richler for the hours and hours of philosophical talks. as well as supervision in our clinic, and Dr. Benjamin, who sat me down 3 months into residency to get all of my professional ducks in a row. So I am open for questions, but it's also okay if you don't have any.
You've got some on Zoom, but I don't know if anybody here in the room had a question. This is so the Zoom people can hear the question.
Thanks for that great talk, Howard. You mentioned some of the cultural differences and the really sparseness of data related to that, but I'm wondering if there's been any studies looking at regional or international countries that maybe manage aging better than we do and what we can learn from them. The Dementia Villages is obviously part of it, but I wonder if there's more to learn.
Yeah, as far as different approaches, Dementia Villages is probably the most different in how we approach care of our elderly patients. Most other countries approach it very similarly with skilled nursing facilities and memory care units.
I have no idea whether this is true or not, but it seems like you could divide the world into cultures where elderly people live with their families for their entire lives, and cultures where at a certain point, older adults are on their own. It would seem like that would be an important variable that would separate cultures. Did you come across that?
I did not, but I think if we look at the statistics, going back to how 5% of the American population currently resides in a skilled nursing facility, I'm not sure how that breaks down in terms of culture or ethnic backgrounds, but there is, in some cultures, there's much more of an emphasis on older adults living with their children, whereas that is less of a case in American culture in general.
And by the way, it was a lovely presentation.
Well, we've got a couple of comments and questions in the chat, and I'll go through them quickly. Simon looks like a fool. First comment. Dancing is great for all older adults in particular. Sleep is also helpful in promoting healthy aging. And the question is, can the rate of healthy aging be slowed down?
Probably, I think different from how we traditionally view aging. I think things like good diet, continued physical activity, good practices slow down the physical effects of aging. Of course, with every passing year, our body physiologically gets older, but there are things to help mitigate that and slow it down.
Comment, thank you for a great talk. Your thoughts on anti-aging supplements such as NMN? I don't know.
Oh, I'm unaware of NMN. So
I've never heard of it either. I had a question. I don't recall you specifically using the word loneliness, but a lot of what you talk about in terms of social connections, and I've noticed this phenomenon since I was a child, and I've been paying more attention to it as I get older. But when a spouse dies, very often the surviving spouse passes away not long thereafter. I don't know if anyone's ever studied that, but this whole idea of loneliness, plays into that. I don't know what your thoughts are on that.
Yeah, so all of the research supports that loneliness kills. It's really well established in the data. I just didn't frame it as such. I wanted to be more strength-based today. But yes, loneliness does kill.
No, but I mean, seriously, and people have been writing about it's not just in older people, right? In particularly in the United States, that loneliness is a serious problem. And if we're going to take steps for healthy aging, maybe one could do something about that, or society can do something. Your immune system, yes, that's true. Hold on.
I have a comment and a question, sort of. So the comment is that there's also a lot of evidence, and we saw a lot of this with COVID too, that there's that instead of dependence, that sort of interdependence. And often you'll find that a spouse or a cohabitating person is compensating for their loved one. And when one dies, some of that compensation goes away, and then you'll see loss that was there, but you didn't see before. So that's just sort of one thing that we see a lot of. You started out sort of referencing and commenting a little bit more pointedly about some of the stigma around aging in this society. I was wondering if you could expand a little bit on how we can help fight that and how we can help to allow people to age more gracefully and fully without the stigma of our colleagues and society at large.
Yeah, I think that boils down to using that 5M model. I think, when we conceptualize our patients, I think it's time that we incorporate these different facets of their health. What constitutes an older person? Someone who's 65, not necessarily. They can still very much be fully functional. The likelihood of them being fully functional is higher than the likelihood of them being not fully functional, right? So.
Thank you, Howard. I read a paper when I was in training that was very illiterate called Trauma, Telomeres, and Training, talking a lot about how telomeres shorten extensively over the time of medical training. It's a little bit sad. No offense to any of us. I wondered if you saw anything about how chronic stress and kind of that chronic level of acute stress plays into aging. I'm thinking kind of in relation to kids, like we talk about like the allosteric loads of stress, how they build up for trauma. Is there anything that kind of correlates into adulthood?
Yeah, so chronic stress is correlated with poorer functioning in later life and also increased morbidities and mortality. That's why I wanted to share some of that research that shows that it's not about it's partly, from the amount of stress that we have, but there's a big part of how we cope with that stress and manage that stress that plays a vital role in how we age and move forward.
All right. Well, listen, thank you very much. It was an excellent presentation.